disturbing, processing mind or other people if there's voices going on in between. So let me try and share this. Meet the last person. Here we go. So, welcome everybody. Today we're going to be talking about predicting mast cell tumor behavior, which is quite an interesting issue, and lots has been researched about this topic, and still remains to be researched, and that's often an indicator that we don't have it perfectly fine. So I'm going to try and give you a current overview clinically where we are, as we go through things. Okay, so today we will be talking, let me see, I don't know if you can see this. We will be talking just a bit of a general mast cell tumor overview. I'm not going to spend too long on it. I'm making the assumption that all of you know what mast cell tumors look like, and you see plenty of them in your clinic. But just to set the scene a little bit, and then we will talk about different prognostic indicators and what we can potentially consider in our cases. So mast cell tumors in dogs, it is a very common skin tumor, and it's about 20% of all skin tumors in the dogs will be mast cell tumors. Okay, often we will see them as just solitary nodules within the skin, although it's well known that definitely up to 1 in 7 dogs can develop more than one mast cell tumor in their lifespan. But we will often consider these as simple entities and not related one to another unless they are recurrences or in the vicinity from the previous one. Okay. We mainly see them in a cutaneous fashion, although they can infiltrate subcutaneously, or we can see them less commonly originating within the subcutaneous space. Now, I won't really be discussing these in particular today because subcutaneous mast cell tumors behave differently than the cutaneous ones, which we see more commonly, and which we know an awful lot more about the markers about, although we're getting up to date with the subcutaneous ones. We know that certain breeds predisposed, and that depends a little bit with part of the world you live in, and what breeds are more common. So they can occur anywhere in the body, and about half of them will occur on the body of our patients, about 40% on the legs, which throw up their own issues really with trying to remove them, and about 10% are head and neck really. Now, they are often called a great pretender, and they can look very differently. So one mast cell tumor won't look like the next one. They will vary in how mobile they are. They will vary in how soft, palpable they are, what their margins are like, what the surface of the skin is doing. They could be hairless or they could be haired. So they can pretend to be anything. And often these tumors, or it's not unusual for dogs with these tumors to come into the clinic with a lump that's been there for quite a while, never caused any problems, and they come in for a completely different reason. But when we sample that lump, we find out it's a mast cell tumor. And obviously the question starts, what do we do with it now? It wasn't causing any issues, but is it going to be causing issues in the future? Katerina, would you mind muting yourself? And about, as we said, 10 to 15% of their lifespan, or at the same time, could develop multiple tumors. Okay. Now, diagnosis of mast cell tumors is quite straightforward, although they can pretend to be anything clinically. Aspiration is the answer to your problem, really. So aspirating the mass, you will typically find round cells and to quite a high number often. And as a typical appearance, they will have these bright purple granules within them. As they become more poorly differentiated, they might have less granules, or when they degranulate, so they might be harder to find. And often with the in-house water-based staining, they might be harder to see as well. Okay, so, but still, on a lot of our preparations, you will find this purpleness, which you can often even see in a well-differentiated mast cell tumor, even when you just do the smear and do your staining without a microscope, you will notice how purple that this whole slide is really. But it's worth remembering that you will have a low number of mast cells, other inflammatory problems, or in other some neoplastic lesions, we can find them as well. So just the presence of a few mast cells does not make it a mast cell tumor. Now, what we're going to talk about today is the prognosis, and the prognosis can be very variable, and it can go from an incredibly benign tumor to a very highly aggressive malignant tumor. And often the problem we have is how are we going to estimate what this tumor going to do, or how are we going to predict what this tumor going to do, because that might guide what we're going to do to treat them as well. So when we go from start to finish, we can see several indicators there. So I'm going to try and group them a little bit into the initial presentation. Are there markers there that you should be worried about? We're going to talk about the main one that we've been using for years and years, and the histological grading and how had the modified over the years. We'll talk a little bit about cytological grading as this is coming up, to get some idea from that point, staging, and then the molecular markers, which you can request at certain labs. So there are certain clinical indicators of mast cell tumors that will worry us more from the start. So a tumor that is growing rapidly is often and quite logically going to be associated with a higher growth rate and therefore a more aggressive behavior. Now, that shouldn't be confused with when these tumors degranulate, and that can happen on aspiration or on friction. These tumors could increase quite suddenly in size, but that is then inflammation-related increase. And these are the one tumors, besides maybe hemangiosarcomas, where owners could come in and say, there's a big lump here, it wasn't here yesterday or the day before, it has come up. And within a few days, it might go down again as that inflammation settles down. So the sudden expansion in size on that occasion is not necessarily tumor related, but it's inflammation related. Okay. If you have a locally irritated mass, or the dog is quite annoyed by it and nibbles at it, or there's quite a lot of inflammation or redness surrounding it, that is another indicator. And if you can't easily find the edges of the tumor, so poor demarcation is a poor indicator, because often that will be associated with infiltration. Okay. Ulcerated masses, if they have little satellite nodules, so what that means is you've got a big nodule, obviously your main mass, but when you start clipping it up about a centimeter or a few centimeters away from the mass, you find smaller nodules present. And the dogs that have systemic signs, which are often related to, again, the degranulation or increased histamine release, and GI ulceration potentially. And then larger masses, so anything bigger than 3 centimeters overall is an indicator for a poorer mast cell tumor behavior. Now, that doesn't mean that we can't find any low-grade tumors that are larger than 3 centimeters, but if you put all the masses that are larger than 3 centimeters in a group, overall, they'll do worse, those patients, than the dogs with a mass that is smaller. So when we then look again at how these patients present, there's definitely certain breeds that we associate with more often benign or well-differentiated tumors, and boxers and pugs are one of them. And we associate Sharpays often with high-grade or aggressive tumors. Okay. And then the location of the mass could be playing a part as well. So we know that the oral, perioral, muzzle tumors, preputial tumors, and inguinal tumors, and then the ear-based tumors have a higher rate of lymph node metastatic disease, and therefore worry us more. And again, these are also in areas that are not easy to remove. So, but location is definitely a factor we should be considering. So then have a brief overview and almost a time frame of what happens with the histological grading. So this is what you're going to get back from your lab, your plain lab sample, if you end up removing it, or if you do an incisional biopsy. So we very rarely will do incisional biopsies unless these tumors are not resectable. Okay. If you do, there's a good correlation with your final histological grading. If you do an incisional biopsy, there's a slight chance, depending how big your biopsy is, that your biopsy is slightly better area. But nonetheless, often that will give you a good indication. Okay. The idea is very much if you can't remove them with appropriate margins, then an incisional biopsy for planning purposes is probably a better way forward than taking them marginally out, because we know that recurrent tumours have a poor prognosis compared with the first cut is the most likely one to cure them, really. So the original grading system that we always used to use is what we call the Patnai grading system. And he developed a grading system with the 3 grades. So grade 1 being low grade, 2 intermediate, 3 being high grade. And it splits up that there's probably a minority, say about 15% of the tumours fell into the grade 3, about 5-10% fell into the grade 1, and the majority of the tumours everybody used to group in the grade 2. And that was quite frustrating because we knew that grade 1 tumours pretty much lived forever. Grade 3 tumours pretty much all died from disease. And grade 2 could do whatever. They might live, they might not live, they might spread, they might not spread. So that was causing some issues to decide what we're further going to do. And another issue that with that grading system is when they started assessing it between different pathologists, because there wasn't a very subjective criteria set, is that they found that if you gave the same tumor to different pathologists, you might get different grading outcomes. So, and therefore that would potentially influence what was done with the patient. So that was not an accurate way of doing it. So Kupel in 2011, then after doing his research and showing the intervariability, decided to make a 2 grading system, so a low grade and a high grade. And he very much put up very objective criteria on what would constitute a high grade tumor. So more than 7 mitotic figures per 10 high power fields. He looked at the number of multinucleated cells, basal nuclei and karyomegaly. And if any of those numbers were higher than the cutoff, then he would give them a high grade. If all of them were below it, it would become a low grade. Now, again, there's certain criteria that we know that might well be important that aren't considered in the Kupel grading system. So the local invasiveness or the granulation of the cells is not really considered. But when he split his group up initially, he found that the median survival time of the low-grade tumors was more than 2 years and of the high-grade tumors was less than 4 months. Okay. Now, over time, people have been looking at both grading systems and trying to compare them because they found that although Kupel one was a very reliable system and most pathologies, they graded them as the same way, they still found that there was a population in the low grade that still kept dying of their disease. So it wasn't necessarily a completely reliable system from that point. So when they compared the Patnai with the Kupel for different tumors, they found that pretty much every tumor that in a 3 grading system was a grade 1, became a low grade in Kupel, and every tumor that was a grade 3 fell into the high grade in Kupel. But that grade 2, that middle group, that big middle group, there was a variation there. So the majority was still falling into the low grades, but depending on the study, say about 1 in 5 dogs was behaving like a high grade or was falling into the high grade pathology staging from Kupel. And so when they then started splitting these dogs up and we kind of then made it into a 4 grade grading system, if you look at a 2 grading system combined, we said grade 1, low grade in Kupel, fantastic prognosis, pretty much they're going to live forever, which we've always thought. Grade 3 in the old grading system or high grades in Kupel, if they have those 2 combined, then very aggressive tumors, but about 75% of those dogs will die from their mast cell tumor, and the median survival time is 3 to 7 months. Okay. And then that middle group, they split them out. And if you look at the survival curve, you can see that there is that yellow line on the top, very close to your low-grade tumors, where these are the population of dogs that had a grade 2 tumor in the Patnai and combined with a low grade in the Kupel. And then you got quite far below that, you've got the orange line, which is the grade 2 in the Patnai combined with a high grade in the Kupel. And there was a big difference there. We found that that grade 2 low grade group, again, lived on to live pretty much forever. Median survival time was over 7 years. But that high grade group, that they were dying quite often from disease, and more than half of those in some studies died from their disease. So again, that is the group that we needed to look at a little bit more there, really. So brief word about cytological grading of mast cell tumours, and people have been looking into this for years because obviously we often find these on cytology. So can we get any indicators on their behaviour from the cytology? Some people are getting better on these. We are starting to look at proliferation markers on the cytology as well. And then more and more indicators or cutoffs being used of what would indicate a more malignant or more likely malignant tumour. And we found that these are relatively accurate grading systems now, and that they are related to the median survival time and tumour-related deaths in one of the studies. But there is a slight risk of overestimating the aggressive behaviour. So if your cytology would be suggested of a low-grade tumour, that is pretty reliable. But if your cytology is suggestive of a high grade, you're still going to find some dogs in there that eventually your histology will say it's a low-grade tumour. Okay. So then we come to the second bit, which sometimes we do before surgery if these dogs have tumours in different locations, or sometimes we end up doing afterwards if the original histology shows it's a high-grade tumour or that grade to high-grade proportion. So we know that staging, that there's a higher risk for spread if you've got a higher grade tumour. And the staging system is going through a bit of a modification as well. So this was the original staging system put up, where you go from a grade 0 is an incompletely excised, so microscopic disease, but no spread. You then move on to grade 1, grade 2, you got some lymph node spread. Grade 3 originally was talking about multiple tumours or a large infiltrating tumour. Now, we these days are thinking that multiple tumours, if they're in different locations, are not necessarily any differently behaving than the solitary ones, and we need to consider the behaviour of each of these tumours or the grading of each of these tumours. And then 4 would be a tumour with any distant mets present. So if we look at where mast cell tumours spread to, and what we do for staging is we always going to aspirate the local lymph nodes and the liver and the spleen. Now, certain studies have pointed out that it's highly unlikely for these tumours to bypass the local lymph nodes and go to the liver and the spleen. But one caveat with the local lymph node is very much, since we're doing sentinel lymph node staining in some of these, that we find out that up to probably 60% of the mast cells in certain studies are not draining to the nearest lymph node or the one that we think they should be draining to. So we might well be sampling the wrong lymph node in those patients, okay? So what we as well know now about clinical staging, obviously a higher stage overall is associated with a worse prognosis. Definitely if you get to the distant mets or the very large tumours, we know that they have a worse prognosis on average. The one with lymph node mets is slightly more nuanced. So we know that dogs with lymph node mets always have been more likely to die on average, but we do know now that it depends on what we do with those lymph node mets. So there's definitely enough studies both in the intermediate grade, so in the old grading system, that intermediate grade population, where it will affect survival. Sorry, that means affecting survival in dogs where the lymph node was removed versus when the lymph node wasn't removed. Okay, definitely there's early metastatic disease there. And we know even in the high grade tumours that if we either can remove that draining lymph node or radiate it in certain occasions, that area, that those dogs do better. So treating the regional lymph node is important in treating our dogs with mast cell tumours. Okay. Now, what we know as well is dogs that have recurrent tumours have a worse prognosis, and it's more likely in dogs with high-grade tumours. So when they look at a recurrence, and there's lots and lots of studies done about margins and possible recurrence, but we would generally say, I mean, a grade 1, even with minimal margins, is unlikely to recur. Okay, and that's the same with the low-grade cupule. And then even if you look at your higher grade tumours, up to 40% will recur, even though your report says clear margins. So those are definitely things to consider. Now let's talk about the proliferation markers, and these are definitely the new kids on the blocks, really. So proliferation markers mean these markers are more present in cells that are either dividing or they might be at a higher rate in cells that are dividing quicker. Okay, so these are cells that are going through an active division process. So what we're trying to establish on the histology is how many of these cells are growing or dividing. And there's three main markers commercially that we can look at or that we can request. So mitotic count is one. Now, mitotic count means we can visually see the cells going through the mitosis process on histology, on plain stained histology. So they need to be into that mitosis phases, really, of your cell cycle. These stages, the synthesis stage and the G2, these cells are still active, but we won't be able to visualize that on plain histology. So that is where the markers of the AGNO and the Ki67 are coming in. Okay. We'll talk through them each separately. And it's a bit easier to get definitely in the UK a Ki67 than getting all three of them done. But I think let's talk through them. But what we do know now is probably we need to consider them all together to find out more accurately what the prognosis would be. So mitotic count is considered an acupal grading system, and the number that they use as a cutoff is 7. Different studies have looked at different cutoffs. So people have looked at 4 as a cutoff. People have looked at quite a big study, which I'll show you the stats on in a minute, have looked at a mitotic index of 5 as a cutoff. And there was a marked difference there in the survival time between more than 5 or more and less than 5. People then started putting them in 3 groups and say mitotic index less than 1, again, they live forever. Mitotic index 1 to 7, there's some of them that die off and your median survival time is 18 months. And more than 7, your median survival time is quite low. So again, this comes back to, I mean, if you've got a mitotic index of 7, there's probably very little evidence that requesting your Ki67 or your AGNO will give you any additional information. These are highly malignant tumors. If they're less than 1, it's unlikely they're going to behave in a malignant way, although there's still a percentage of the low-grade tumors that will spread to the regional lymph nodes. So that does not mean you shouldn't stage them. And there is that middle group again. So we know that the mitotic index does not reflect your risk for local recurrence. There's other markers there that we look at, but it will reflect your risk for spread of disease. Okay. So, but as we said, because it only looks at the cells that are in the M phase, you could be underestimating behavior. So these are the Kaplan-Meier curves or the survival curves of that study with the mitotic index of 0 till 5 or more than 5. And in all of them, so they split them up. Initially, they looked at all the dogs with mast cell tumors where there's that big difference. So 70 months is give or take, what we're talking 5.5 years. If we then split them off to dogs even that didn't have metastatic disease on staging, very similar figures. And if we split them up between grade 2 or grade 3, again, there's that big difference. With grade 3, even the ones with the low mitotic grade still have a median survival time that is quite high. And if you look at the line, median survival time more than 16 months means, none of them died. So it could be going on for a lot longer as well. So then people started looking at the Ki67 because Ki67 staining will be present in cells that are actively dividing. So almost through that whole cell cycle, but not in the resting phase. Okay. So when they looked, and there's 2 numbers depending on which lab you're using, they either use a grid area and they count the number of positive cells. So it's 23 or more. Then you got an increased risk for disease progression and mast cell tumor related mortality. And the same if they use the 1.8 cutoff, they're 1.86. So then we generated the studies that looked at, hang on here, that's great, but we're now starting to see tumors coming out with a mitotic count that is low and a Ki67 that is high. So what do we do with these patients now? And several studies have looked at these group of patients. And again, it's a very crude estimate, but out of those studies, we concluded that Chi-67 being high is sensitive but poorly specific. So what that means is if it's high, it's not a reliable predictor of the mast cell tumor death. If it's low, it means that it's highly unlikely they're going to die from their mast cell tumor. Okay. Mitotic index is the opposite. So a high mitotic index is accurately predictive of tumor-related death, but a low mitotic index does not rule that out. Okay, so if you want to look at it simplistically, mitotic index potentially will underestimate behavior if it's low, and Chi-67 will potentially overestimate aggression if it's high. So the last stain we're going to discuss is the agnor. So the agnor is a silver staining nuclear area that is activated if the cells are going to divide, and it stains more if there's more of it if they're going to divide quicker. Okay. And this seems to be a good indicator, but they found it was even more accurate when they look at both the agnor together with the Chi-67. And that seems to be the best indicator for predicting tumor-related death or tumor occurrence, really. So decreased disease-free interval. So what they found is if you had a low AG67, so the combined of the two, if that was low, with either an intermediate grade or low grade cupule, that is highly unlikely for that tumor to occur, unrelated to what the margins are saying. Okay. And they found in a later study that was the same conclusion. So it's mainly recurrence that we're looking at here, really, that was similar, independent of the mast cell tumor grade. There's two more things you can request. I mean, definitely they might have to go to the States, these samples, but you can request was your kid's protein staining, the localization, if it is in the membrane, the cytoplasmic membrane, if it is focally within the cytoplasm or diffuse. And that seems to be related as well to the risk of dying from their disease. Okay, and as you go through the different patterns, you will see a significantly decreased disease-free interval and survival time. However, recent studies say this is all good and well, but your main indicator is how these dogs respond to treatment if we are talking about tyrosine kinase inhibitors. So the dogs that respond to treatment, if they have metastatic disease or if they have recurrent masses or scars, the dogs that respond will do better irrespectively of what pattern of staining they have. Okay. And the same with the c-KIT mutation. So the initial study said if you have a mutation in exon 11, and c-KIT is the gene that's often affected in mast cell tumors, then these are more likely to be aggressively behaving, but they're more likely to respond to tyrosine kinase inhibitors. If you have mutations in exon 8, they're not associated with a poor prognosis. But again, coming back to the latest studies, response to treatment is your main factor that is influencing your prognosis here, really. So with the latter two, I very rarely will check them because I either will treat them and see what they do with tyrosine kinase inhibitors, or we won't treat them. And often by the time you get your results back of the last two tests, you already will know if they're responding to the treatment or not. So when do we do this extra panel in the clinic? I think we will definitely do it where we think we get conflicting results. And that might be conflicting results either between what we get in the clinical behavior or the presentation. So if we see a sharp A and it says it's a low-grade tumor, then I will request the extra panel and vice versa. Okay, so if we get that conflicting issue, if we have an ulcerated mass, but it's a low-grade tumor, if we have a low-grade tumor, but it's got a borderline mitotic grade, so maybe somewhere between 2 and 5, or if it's got a low mitotic grade, but it's got other markers of malignancy on this histology, then I will potentially consider requesting those to get just that little bit more information. I very rarely will do them if I've got a mitotic rate, a mitotic count of less than 1 and a grade 1 tumor, or a mitotic rate that is above 5 and it's reported as grade 3 tumor. I mean, we already have two important markers that would say it's one or the other. I think those extra ones will not necessarily add anything to it, and they are not cheap to run. Okay. So, I mean, there's so much more to say about mast cell tumours that we haven't talked about today, and maybe this will come up in one of the future talks. But obviously, there's different behaviour for subcutaneous mast cell tumours. How much margins do we need to take in surgery? What is appropriate? Should we follow these up? Should they have a repeat surgery to remove the scar? What we're talking about, sentinel lymph nodes. Again, we've already done a talk earlier in the year about this. And then the different treatment options. What is the right dog to send for chemotherapy? What's the right dog to consider radiation with or repeat surgery? But unfortunately, that wouldn't fit all in today's talk. However, I hope you all took quite a lot away. And if you've got any questions, please speak up and I'll try and answer them for you. And then we'll see who next week can make it, where we're going to talk a little bit more about gastroprotectant drugs and mainly drugs like omeprazole. Are they all as benign as what we think they are? And what is the risk with using them? So we'll have a chat about that next week for whoever can make it at that point. So I'm not sure if anybody has any questions for me today. And thank you all for joining. I know a lot of you are probably on your lunch break or dinner break. And thank you for taking time out in the day. I have either overwhelmed everybody with what I've said or everybody's fallen asleep, but everybody's been very quiet. Okay. Well, in that case, I'm going to wish you all a good day. If you've got any topics that you want us to discuss, drop us a quick line, either on LinkedIn or send us a quick email, and we can definitely discuss it. And we'll go from there. But I hope everybody has a good day. All your patients are doing well. Happy to see that you're not sleeping, Hira. Thank you. And